Good afternoon, everyone. I'll be presenting a respiratory system case. This is a 70-year-old gentleman, Mr. M, from Vellore. He's a daily wage worker who presented with fever for 2 months, cough for 2 months. He was apparently well until 2 months back when he developed fever with an evening rise of temperature associated with chills and rigors. No night sweats, no documented temperature. The cough was insidious onset, gradually progressive for 2 months with minimal mucoid expectoration. There was no hemoptysis, no postural, diurnal, or seasonal variation. He also had a left-sided chest pain for 2 months, which was a lancinating pain, worsened on cough and deep inspiration. He gives history of unintentional loss of weight in the last 2 months, which was not quantified with an associated loss of appetite. He had no history of nasal discharge, sore throat. He had no history of dyspnea, palpitations, syncope, swelling of face or feet. There was no history of pain abdomen, vomiting, loose stools, no diplopia, headache, vomiting, blurring of vision, no history of hoarseness of voice, dysphagia. There was no connective tissue symptoms suggestive of connective tissue disorders like joint pain, rash, oral ulcers, dry mouth or eyes. Past history wise, he was diagnosed as sputum positive drug susceptible TB in 2022. He defaulted on ATT after 3 months since he felt improvement in his symptoms. Due to recurrence of fever and productive cough, he was evaluated elsewhere and diagnosed with sputum positive drug susceptible TB in 2023. And at that point, he completed 6 months of ATT regimen, which was 2 HRZD plus 4 HRE. He has no comorbid illnesses, no surgeries in the past. Personal history wise, he's a reformed smoker, taken 3 to 4 cigarettes per day for the last 50 years. Last smoke was 3 years back, a total of 10 pack years. No alcohol consumption or other addictions. His bowel bladder habits were normal, sleep and appetite were normal. No TB contact history, no recent travel history or vaccination. Summarizing the history, this is a 70-year-old gentleman with history of sputum positive pulmonary drug susceptible TB earlier, defaulted in 2022, then completed 6 months of ATT regimen in 2023, and a reformed smoker, currently presented with 2 months of fever and progressively worsening cough with a loss of weight and appetite.
So, shall we just stop here and we'd like to discuss on your symptoms, and can you tell us which system it pertains to and which are the anatomical structures which could possibly be involved?
It's a good comprehensive history. You have summarized it quite well. Can you now localize where? Like Dr. Karthik wanted to know, where do you want to localize your pathology? Okay.
The patient had history of fever associated with cough, which was productive. So I would localize it to the respiratory system, the lung parenchyma.
Let's go back to the symptoms slide. So you're saying it's a parenchymal involvement based on the productive cough. Okay. And what are the other symptoms that this patient had?
He also had a left-sided chest pain, which worsened on cough and deep inspiration.
What is it?
A pleuritic type of chest pain. Pleuroparenchymal.
The average could be involved.
Could be involved. but he did not have history of dyspnea, worsening dyspnea, so that is a
So
little
your patient-
against.
He had some history of TB in the past. He's been having some cough and bloating pain. He never had dyspnea. So
Dyspnea.
did you go back and ask the patient
Yeah.
about history of dyspnea?
Yes, sir.
And he denied.
He denied.
So he was able to do his activities.
Yes, sir.
No restriction. And no
Yes.
cough. Surprise. Okay, so cough again with the predictive cough, it can also could either be the airway involvement or the parenchymal involvement. And he's also got a left-sided, I mean, with what Mr. you got, sounds more like a pleuritic involvement. So now we are looking at a patient who's been having fever for 2 months duration, and they've been having cough, which is protective. You're thinking more of a parenchymal or airway involvement, and he's also got a pleuritic chest pain. So what are your thoughts? I mean, when you look at these symptoms, so what are the things which comes? I mean, anatomically, we feel it's probably involving the left side of the chest, or it could be a bilateral lung disease. And so it's probably the parenchyma which is involved, and also the pleura. So what are the different pathological process that you are considering in this patient?
Because he gives history of fever with productive cough, I'd like to think of infection, a chronic infection. It was ongoing for 2 months.
Yeah. To look at the pathology. So what is the pathology, not the etiology?
So chronic suppurative lung disease.
You convince this is a suppurative.
No, there is no much of production.
It's all small.
Yes.
So it's not fitting into a suppurative. You mentioned it's only minimal mucoid. So it's not classically fitting into a suppurative.
Yes. So consolidation.
Okay.
Um, inflammation, pleuroparenchymal disease involving the pleural inflammation.
History of your findings, it's all fitting into a pleuroparenchymal disease. So Dr. Karthik wants to know where exactly. Is it like a consolidation? Roughly, you
Yes.
can guess from the history.
What
More
are
of a
symptoms that you see?
consolidation.
No postural diagnosis. So you cannot comment about seasonal when the symptoms are 8 to months. It's a little thing we need to consider. Postural and diurnal definitely is. If it is 2 years duration, yes, you have to comment about seasonal duration. But if it's shorter duration, 2 months, you need to comment about diurnal and postural, but not seasonal.
Okay, so you're thinking of a parenchymal involvement, and you're thinking it could be a consolidation. So why is this patient having pleuritic pain?
Because of the inflammation of the surrounding pleura.
You want to consider that patient probably got a pleural effusion. With that,
But he did
What
not
do you
have
think?
any postural variation in the cough. There was no dyspnea per se.
Yeah.
So I would think less likely for a pleural effusion.
Want to consider pleural effusion as less likely because the patient did not give any history of dyspnea, and you're saying there's no postural variation. So what do you mean by postural variation? So somebody with a pleural effusion and postural variation. So
Pleural effusion patients tend to lie on the same side of the pathology.
they tend to lie on the same side of the pathology. Why is that?
If they lie on the opposite side, the other lung is also compromised because of if it's a massive effusion.
Other lung gets compromised.
Uh,
Okay. So why would somebody have pain in a pleural effusion? or when there is inflammation of the pleura?
Because the parietal pleura is pain sensitive. So inflammation of the parietal pleura will have pain.
Understand that the initial phase of pleurisy will have pain. And once the effusion is set in, unless it is an alpine one, the pain will usually disappear. Understood? Both the pleura is inflamed and they rub each other, it causes pain.
Yes.
But once effusion splits the pleura, usually the pain will disappear. That is how the classical pleuritic chest pain to effusion evolves. So in this case, you have mentioned that 2 months, there is constant pain. Is it still there or is it set with time?
It is still there, sir.
And it is a typical pleuritic pain.
Yes, sir.
And in which position is he lying down?
He's lying down on the same side. He's lying down on the left side.
That it is bleeding.
Yes.
It is very classical upper pleuritic pain.
Okay, so can you just summarize and tell us what is the anatomical structure, the pathology, and what is the possible etiology that you would like to consider in this particular patient?
So this is a 70-year-old gentleman who presented with 2 months history of fever with an evening rise of temperature associated with progressively worsening productive cough and a left-sided pleuritic chest pain with constitutional symptoms. Anatomically, I would like to consider it a pleuroparenchymal disease. Pathologically, I would like to call it a consolidation. And etiology, probable chronic infection of the lung, infective bar inflammation of the lung.
The past history of significant tuberculosis history.
Yes.
Once he is defaulted, now he is having fever for 2 months associated with these symptoms. Still consider a tuberculosis reactivation or the development of multi-drug resistant tuberculosis, at least in this setting.
Yes.
It should be a first differential because there's such an endemic condition.
Yes. Yes.
Other differentials like fungal can be associated, but the common things are common.
Yes.
I will still put my differentials as either reactivation of a drug sensitive TB or a development of multi-drug resistant TB in this setting.
Which TB patients are at risk of having a reactivation in terms of pathology?
Those who have an underlying malnutrition or diabetes mellitus, or those who are on steroids or other immunosuppressants.
Well, compromise have a good chance of activation, but in terms of pathology, like if you have a TB, pleural effusion, or presenting like a consolidation or a cavity. So among this, which is the one which has the higher risk of reactivation?
Patients who have cavitatory lesions.
Patients with cavitatory lesions have a higher chance of reactivation, and treating them also becomes quite challenging to develop. Okay, go on to the examination.
On examination, the patient was conscious, cooperative, oriented to time, place, and person. He was a thin-built and poorly nourished gentleman with temporal hollowing, loss of buccal pad of fat, and sunken eyes. Pallor was present. No icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. There were no external markers of tuberculosis or malignancy. There was no BCG scar. His height was 155 centimeters, weight of 42 kgs, and BMI of 17 kg per meter square. Coming to vital signs, he had a pulse rate of 88 per minute with a regular rhythm, normal volume, and no specific character, equally felt in all peripheral pulses with no vessel wall thickening. There was no radial or radiofemoral delay. Blood pressure measured in the left upper limb in sitting posture was 110 by 80 mmHg, respiratory rate of 24 per minute, abdominothoracic type of respiration. Saturation on room air was 95%. His temperature was 98.4 degree Fahrenheit and JVP was not elevated. On inspection of the upper respiratory tract, the external nose was normal. There was no nasal flaring. The nasal mucosa appears normal. There was no deviated nasal septum or turbinate hypertrophy. There was no nasal or bleed, discharge or crus or polyps. There was no sinus tenderness. Oral cavity examination showed poor oral hygiene with dental caries. There was no halitosis or oral thrush. The other structures like gums, buccal mucosa and lips, tongue, tonsillar pillar and pharynx were normal. An examination of the lower respiratory tract, the trachea appears to be shifted to left with the trail sign positive. There was bilateral supraclavicular and infraclavicular hollowing present. The chest wall was elliptical in shape and symmetrical. There was no chest wall deformity. Chest wall movements appear to be equal on both sides of the anterior and posterior chest wall. Apical impulse was visible. There was no intercostal indrawing or intercostal fullness. There was no drooping of shoulder. There was no scar, sinuses, dilated veins over the chest wall. There was no visible pulsations present. There was no spinal deformity. On palpation, the inspectory findings were confirmed. The trachea was deviated to the left side. Apical impulse was felt on the left fifth intercostal space, 1 inch lateral to left mid-clavicular line. There was no rib crowding. Chest movements in the upper and lower anterior chest wall, upper and lower posterior chest wall, and the apical region were equal. Coming to the chest measurements, the AP diameter was 21 centimeter, transverse diameter was 26 centimeter. The AP is to transverse ratio was 0.8. Chest expansion on inspiration was 79 centimeter. Chest expansion on expiration was 78 centimeter. The hemithorax on inspiration was 40.5 centimeter. On expiration, it was 40 centimeters. Left hemithorax on inspiration was 38.5 centimeters. On expiration, it was 38 centimeter. Spinoscapular distance on the right side was 13 centimeter. On the left was 11 centimeter. Spinoacromial distance was 15 centimeters on the right and 13 centimeters on the left. The vocal fremitus was increased in the left infraclavicular, mammary, axillary and infraaxillary areas. In the other areas, vocal fremitus was normal. There was no tactile fremitus. On percussion, there was an impaired note on the left infraclavicular, mammary, axillary and infraaxillary areas. On tidal percussion, the dullness in the fifth intercostal space changed to resonant note on full inspiration. Throb space was tympanic. On auscultation, there was bronchial breath sounds, more of cavernous type of bronchial breath sounds in the infraclavicular, mammary, axillary and infraaxillary areas. Vocal resonance was increased in the infraclavicular, mammary, axillary and infraaxillary areas. Other systemic examination findings were normal. In cardiovascular examination, the S1, S2 present in all 4 areas. There was no loud P2, there was no murmur. Per abdomen was soft, non-tender, not distended, no palpable liver or spleen, bowel sounds were present. CNS examination revealed no focal neurological deficits. Summarizing my examination findings, this gentleman was cachectic. He had pallor. He had bilateral hollowing of the supraclavicular and infraclavicular fossae. The trachea and apex were deviated to the left side. Vocal fremitus was increased on the right infraclavicular, mammary, infraaxillary and infrascapular areas. On percussion, there was an impaired note in the same areas, right infraclavicular, mammary and infraaxillary and infrascapular areas. On auscultation, there was a cavernous breath sound with an increased vocal resonance. on the right infraclavicular, mammary, infraaxillary, and infrascapular areas. So at the end of my physical history and examination, I would like to consider a diagnosis of left-sided fibrocavity disease with tuberculosis reactivation as a probable etiology with no signs of respiratory failure, congestive heart failure, or pulmonary artery hypertension.
The whole lung is having a fibrocavity disease, or you want to localize only lobe per se? Because you go back to your examination, the other auscultatory areas and other percussion areas seems to be in percussion. It is all. So where do you want to localize?
So the left upper and middle zone, left upper zone, lobe, sorry.
Comes to X-ray, you comment about lobe zones. Here it is.
Lobe.
Most likely localization is a left upper lobe pathology. You want to say it as a fibrocavitary.
Yes.
So what are the points in favor of a fibrocavitary disease?
There was a tracheal deviation to the same side of the pathology, to the left, with an apical deviation to the left side as well. So that is pointing towards fibrosis with the supraclavicular and infraclavicular hollowing also. And cavitatory because of the impaired note in the areas mentioned, and with a cavernous quality of the bronchial breath sounds.
One feature, clinical feature is missing to call it a fibrosis in this patient.
Fibrosis generally has crepitations along, but I could not appreciate any in this page.
Is there any other confirmatory clinical sign to demonstrate or to confirm a cavity? You heard of the term post-acid suction?
Yes.
So whenever you have a cavernous breath sound, you should always confirm it by doing a post-acid suction. So if it is present, it almost confirms the diagnosis of an underlying cavity. Okay.
Why you call it as a cavernous bronchial sound?
It was a low-pitched quality. The sound was of low-pitched quality, and not of a tubular type, like that of the trachea, like how we the tracheal sound is more of a bronchial type, and it's high-pitched, whereas
High-pitched sounds which often you hear it in patients with consolidation, whereas cavernous you often see with patients with cavitational lesion. So why can't this be a effusion? Or sorry, a collapse?
in collapse there is absent breath sounds generally. Even though there is tracheal deviation and the apical deviation on the same side, in collapse there is generally absent breath sounds. But here I could, but here breath sounds were bronchial breath sounds. So,
Character. So the collapse. Yeah, so Ashwin said the crackles are not there, so to call it as a fibrosis. Any other clinical tests you would like to do to confirm fibrosis? You did mention that patient do not have rib crowding. So how do you look for rib crowding?
when we would not be able to insinuate our fingers between the ribs in the intercostal spaces.
You should always do it
Bilateral.
and then you can
Yes.
Patient you should probably do it properly and see if patient has got rib crowding, because if rib crowding is there, then your diagnosis of fibrosis becomes more meaningful. And So according to your findings, you are saying this patient has got a left-sided lung disease and he's got a fibrocavitated lesion. And so what are the diseases which can cause fibrocavitary lesions
Um,
or cavitary lesions? Begin with
tuberculosis, infections like tuberculosis, sarcoid, in terms of silicosis, aspergillosis is also one infection. Or vasculitis like vaginous granulomatosis.
so this vaginous can present with cavitary lesion. The differential could be vaginous. So would you want to give another differential instead of a fibrocavitary? What else answer? Can it be a mass? Patient can have bronchial breath sounds. They can have impaired tone.
Tracheal deviation to the same side.
They have a collapse. Mass with a collapse. It would form.
Yes.
The closed differential will be a mass which is obstructing and causing a collapse. Will be a differential for this patient. Is he a smoker?
He is a chronic smoker.
What other differentials would you consider? Considering past history of TB, technical. This TB is the first TB reactivation is the first differential. Any other differentials would you like to consider have it treated these, particularly in old TB patients?
Aspergillosis.
Aspergillosis, which can range from a simple aspergilloma to semi-invasive to invasive aspergillosis. When that comes after TB reactivation. Any other infection? Not tuberculosis, but
Yes.
intestinal infections can also present with cavitative disease, but it's not as common as but considering the fact that he's having underlying possible COPD, cathextic, malnourished, he's at risk for intestinal infections also. And definitely malignancy, again with this age and smoking history, you need to keep that as a differential. Can malignancy present with cavity?
Yes, sir.
Which
Squamous type.
squamous with cavitated. And like Karthik said, GP, granulomatous polyomatus or earlier called illness also can present it, but usually they are multiple cavitation, not a single cavitation. So that's how usually you need to list the differentials.
Okay, this could go to the next line. Mastication. Okay, that's next one. The resonance was increased. Okay. Why do you think the vocal resonance increased in this patient? So normally, in what are the conditions where the vocal resonance can be increased?
In a consolidation,
Okay, consolidation, your vocal
Yeah.
resonance increase. Why is it increased?
because sound travels faster in solids. So a
Consolidate
consolidated
lung
mass.
becomes a soft lung where the filtering effect of the alveoli is lost, so your vocal resonance can be increased. So why is in this patient in a cavity, what happens to vocal resonance? Or in a fibrosis, what happens to vocal?
Again, there is a consolidate. There's a solid mass through which the sound has to be. Breath sounds have to be.
Solid.
Thick-walled cavity can have increased vocal resonance.
They can have increased vocal resonance if it's communicating with the bronchus. Okay, if it's communicating, then you can have increase in vocal resonance. If not, you may not have an increase in vocal resonance, both in fibrosis as well as in cavitary lesions. Next slide. Go back. go back. Yeah. Sure. So what do you want to do for this patient? So you want to, so based on your clinical history and examination, you're probably considering, to start off with the history, you said probably patient got a parenchymal and pleural involvement, and you did consider it being a left-sided lung disease. But you mentioned saying patient got bilateral wasting in the supraclavicular and intraclavicular, right?
Yes.
Okay, and based on your examination, you said it's a fibrocavitary disease. So, what do you want to do for this patient further in terms of evaluation? How do you want to evaluate this patient?
I would like to do basic blood investigations like complete blood picture, serum electrolytes, his liver function test, urea creatinine. Like to get
How
it.
is the complete blood picture helping as this patient?
Whether there is any associated the hemoglobin.
You'd like to know the hemoglobin, would like to know the MCV. Okay. Yeah, but though he had fever for 2 months, according to your examination, he was healed well at the time of presentation. Right?
Yes.
Okay, what are the other tests you would like to do?
A chest X-ray.
Okay.
Like to do a sputum AFB smear, and an expert TB PCR, and MJ culture.
Can you describe this X-ray for us?
This is a chest X-ray in the posterior anterior view, showing a tracheal deviation to the left. With the with the probable cavitatory lesion in the left upper zone. There is no mediastinal widening. There is no. There is minimal CP angle blunting in the left side as compared to the right.
From the history, it looked like only the left upper lobe is involved. But looking at the radiology, it's like the whole left lung is involved. So that is a little concern, because if you look at an isolated left upper lobe pathology, usually you will have only the tracheal shift. The lower mediastinum usually is undisturbed. If you have a whole lung pathology, usually your upper and lower mediastinum will be shifted. Here in your case, you have actually mentioned that your apex beat is also shifted 1 inch lateral to your midline. So that means definitely there is something more than just an upper lobe. There is more than upper lobe involvement. So here you have upper lobe as well as the whole lung is involved. And like you said, there is blunting of the CP angle. The diaphragm contour is not clear. So that also confirms that the lower lobe is involved. The left heart border is not seen. So again, your lingula is involved. The aortic knuckle is seen, but the other part of your lung is with more or less AC. So technically, it's a whole lung is involved. And in addition, what you can see, there is a compensatory hyperinflation of the other lung. And here in the X-ray, you can definitely see there is volume loss. There is crowding of ribs on the left, which you can easily appreciate very clearly. So that is the findings.
Yeah, so there are infiltrates, and that you can also see some infiltrates coming up in the right. Right.
Okay.
Also, yeah, so there is probably some transbronchial spread of the disease. And as Rashid said, you can obviously make out the wasting and crowding. you need to check that carefully in your clinical examination.
So what will you do next after seeing
A HRCT thorax.
How will the HRCT help?
specialty? So you've done an X-ray, you've done the bloods. What next? Sputum.
Sputum.
What is sputum done for this patient?
Yes. The expert TB PCR revealed a rifampicin susceptible MTB.
Considering the past two episodes of tuberculosis, 2022 and 23, and once he is defaulted, the second time he is completed, how will you interpret these sputum reports? You got my question. So we have a patient who had twice tuberculosis treated. And now came with fever, I agree with that, but his sputum is showing expert positive, but AFB is negative. So will you take it significant or not? If yes, or if no?
Yes, because of a recent history of default, twice he has had TB.
First time he defaulted.
He
I think the second
time he is
completed.
completed, sir. Yes. Considering that in the background and the overall malnourished state, I would like to.
You need to understand that what the principle, how the testing works. How does expert work?
It's a nucleic acid amplification
It's a
technique.
nucleic acid. So even if you have dead gas, say for example, you said there is a fibrocavity, usually will have a significantly dead gas very low. So what or some bug will be engulfed by the macrophages, which will be flying dormant. So if you do a induced sputum or a sputum, you will pick up the nucleic acid of the dead acid. You got it?
Yes.
So that's why expert may not be very useful. Maybe useful when you're suspecting a multi-drug resistance. If it shows resistance, then you will further evaluate. But now AFP is come on the smear, which is negative. So will you still consider this could be a dead bacilli, or you want to? How do you want to proceed?
The MZ culture.
So you want which it takes rapidly growing bugs usually takes about 3 to 4 weeks. Otherwise, up to 8 weeks you have to wait. So you want to send this patient home and call it 2 months or 1 month.
I would like to start the medication.
You are here, you have a justification patient as having ongoing fever, having ongoing constitutional symptoms. Whatever, which has been there for 2 months, and with this evidence, we can consider initiating ATT.
Yeah. So
Say, for example, if the expert comes negative, but AFB smear comes positive, what is your right?
Non-tubercular mycobacterial disease.
Which can be AFB positive.
Lepra bas.
I think Lepra will be there in
cabinet relations.
with this sputum.
Nocardia.
Yeah.
Cardia is another differential which can have a cavitary disease, particularly this kind of host, but a whole TB, malnourished, epileptic, is at risk for nocardia. That is another differential you need to have if you have a expert negative but AFB positive. So always don't restrict yourself to expert alone. Send expert and AFB. That's another issue.
Slides.
How do you want to proceed, Nick?
I would like to start him on a weight-based TB, I would like to start him on HRZD regimen for 2 months with pyridoxine and continuation phase of with HRE for 4 months. And a high protein diet, 1 to 1.5 grams per kg per day, because of his underlying malnourishment.
Any other additional tests considering his background history of TB you want to know? Or would you like to order any other additional test?
A bloodborne viral screen,
Okay. No,
HbA1c.
test to tuberculosis. Anything else specific you want to test?
Line probes.
Why?
Uh,
Why do you want to order line probe and say for the
because he had multiple the past history of tuberculosis in the past. He could
what additional information does line probe assay give?
isoniazid resistance.
Patient had exposure to repeated exposure to first line entity drugs. And in general, there is an increase in INH monoresistance. So I would like to know whether the patient, since he had 2 courses of AT, whether he has developed INH resistance. So in addition to expert and cultures, I would also like to do a LPA. Though I will start the patient on ETT because LPA takes some time. They do it in batches. I will call him after a week and follow up. And based on the INH resistance pattern, I will modify me. That's another important thing you need to consider in patients who had more than one time exposure to AT. Okay.
Anything else you would like to do? The diabetic?
He's not a known diabetics.
And you want to give 300 milligrams. So weight is 41. So expert basically detects what gene?
RPO BG.
So, gene. Okay, so when you have an expert, the Thompson is susceptible and can, yes, I think so. You can have INH monoresistance. So it's very line probe assay needs to be done and follow the cultures also. So, okay. Okay, thank you for this presentation. Overall, it went well, except for a few clinical findings, few places. Any more questions from the audience? Any suggestions or questions? Okay, there are no further questions. Thank you all for joining us for this class on respiratory system, and we'll meet next week. Thank you.
Thank you, sir. Thank you, dear postgraduate. So done an excellent presentation and a detailed discussion. Thank you, one and all. We can end the session. Thank you, sir.